Good morning, everyone. Today, in our series of urology Viva preparations, we are discussing emergency scenarios. Thank you for the trainee who has accepted to record the discussion so that it's a good source for others and for the future reference. Welcome. Our first scenario today is you have a 28-year-old woman, quite fit otherwise, presented to A&E with high swinging temperature and tiredness. The A&E doctors have evaluated her, and since her pain is more lateralized towards the right loin, they did emergency CTKUB, which showed 8 millimeter stone in the lower ureter causing hydroureteronephrosis. Since there is a stone, they have asked you to review the patient. Patient is not very much responding. She's quite tired. She's moaning with pain, and she has high swinging temperature. How will you proceed further?
So I'm concerned that this young female has an infected, obstructed right kidney, which is a urological emergency. I will go to A&E immediately and resuscitate this patient in line with ALS protocol, make sure airway, breathing, and circulation are fine. I would also resuscitate in line with the Sepsis protocol, giving high flow oxygen, taking blood culture, urine culture, and lactates, giving high flow oxygen, IV fluids, antibiotics, broad spectrum antibiotics in line with my local sensitivity guideline, and also insert a urethral catheter for monitoring. Ultimately, this lady requires decompression of her infected, obstructed right kidney by means of an urgent nephrostomy or a ureteric stent insertion.
Okay.
Hello?
Is there any scoring system available to evaluate these kind of patients? What is your working diagnosis?
So my working diagnosis is sepsis secondary to an infected, obstructed right kidney. There is a scoring system for sepsis, which is the sequential organ failure assessments, or the SOFA score, which can be used in the acute setting.
What is Q SOFA?
So Q-SOFA is a quick SOFA which assesses three parameters: respiratory rate, heart rate, and GCS. And a score of 2 or more is likely in keeping with sepsis.
Yeah, but even though the score is 0, clinically, if you feel the sepsis is possible, you need to label the patient and follow the sepsis protocol.
Yes.
Okay, what is the sepsis protocol?
So sepsis protocol is a sepsis 6, which involves giving high flow oxygen, giving intravenous fluid resuscitation, taking samples for blood culture, and in this case, urine culture as well, documenting the patient's lactates, giving intravenous antibiotics, as well as monitoring urine output by means of catheter.
Okay, as you said, there are 6 items which you can remember top to down so that it's easy to reproduce. Good. So you said broad spectrum antibiotic. What is the choice of antibiotic?
So I will give co-amoxiclav, which has excellent broad spectrum cover for both gram negatives and gram positives. I would also give IV gentamicin, which is bactericidal for gram negatives.
What is the protocol for IV gentamicin? How much dose?
So I'll give a dose of 5 milligrams per kilogram.
Okay. What about after 24 hours? How will you repeat and monitor the gentamicin?
So gentamicin after 24 hours, I'll take gentamicin levels to determine if it's safe to give a further dose.
Okay, there is a separate protocol which says you can give the second dose without monitoring. So after first dose, 24 hours later, you can give second dose. After that, you need to monitor in 24 hours to make sure whether the third dose has to be dose titrated or to be skipped into the fourth day or can be given straight away. The concept is 2 doses will not cause gentamicin overloading. So after
Okay.
first dose, we are very confident because that's the first dose. So second dose also can be given. Yes, there is a small clinical possibility of gentamicin overloading, but that will not cause any harm. So from that onwards, the third day, you need to do the gentamicin level.
Yeah.
Okay, good. Okay, you are treating this patient. She is stable now. She is recovering. What is your next steps?
So my next step is urgent decompression of the infected obstructed right kidney by means of a nephrostomy, which would involve interventional radiology. If they're not available, then by means of retrograde ureteric stent insertion in theater.
Okay, why you chosen nephrostomy as the first choice?
So in my practice, I will prefer nephrostomy because this avoids a general anesthetic, but also minimal instrumentation of the urinary tract, and this is done under local anesthesia. However, in the absence of this, I will take this patient to theater and insert a retrograde stent, as evidence suggests that there is no difference between a nephrostomy insertion or ureteric stent, as per Pearl et al.'s paper.
Yeah, that's a very nice evidence to bring in. There is no big difference, but subjectively, at least the clinicians feel that nephrostomy will drain the kidney better. And if there is purulent pus in the system, you can visually see the clearance of the nephrostomy tube and the kidney's recovery with production of the normal urine. While the same pus will be in the bladder, of course, you will keep a bladder catheter, but it will be diluted by the opposite kidney urine. So you won't get the actual visual observation or subjective observation of the recovery of the patient's purulent status in an obstructed system. Okay, let us assume that you don't have the nephrostomy cover and you are taking the patient to theater for JJ stent placement. How will you consent and prepare her?
So my consent process would involve use of a biospecific consent form, and I will discuss the risks, benefits, and alternatives of ureteric stent insertion. I would explain to the patient that this requires general anesthetic, where I will be placing a stent to bypass the obstruction and drain the kidney. The risks include infection, bleeding, damage to the ureter, failure, in which case we'll revert to a nephrostomy, an initial septic shower following stent insertion. And I'll explain to the patient about stent symptoms as well following stent insertion, i.e. flank pain, cystitis symptoms, and on and off hematuria.
Okay, be careful while using the BOWS specific consent form. We have BOWS specific procedure specific information leaflet for stenting, but not consent form for every procedure. If you take BOWS specific consent form, it will be more generic like insertion of a stent. But for this patient, you may be interested to document much more because of her sepsis status and chances of on-table events, and if necessary, you may have to do even more steps to make sure that the stenting is successful. Okay,
Okay.
patient is on table and if patient is well prepared, the antibiotics were checked. If the antibiotics were a little bit few hours late, we can repeat the antibiotics. Anesthetist will take care of that. And what is your approach? The patient has, as I said, 8 millimeter lower ureteric stone, few centimeters above the VUJ. How will you approach it on table?
So on table following WHO check, patient will be positioned in a lithotomy position. I'll introduce a cystoscope, empty the bladder, and send urine from the bladder for microbiology. I will cannulate the right UO with a sensor guide wire and pass a ureteric catheter over the guide wire and try and bypass the stone if possible, following which I would aspirate the obstructed collecting system to obtain ureteric sample as well for cultures. And I will then do a retrograde study after emptying that collecting system to delineate the pelvic ileal system and deploy a stent in that ureter. This will be confirmed with fluoroscopy guidance as well as direct vision.
What size of stent you will choose?
So this will, depending on the height of the patient, I will use a 6 French by 24 or 6 French by 26 stents.
Okay, if there is a difficulty in placing 6 French stent, what is your choice?
So I could go down to a 4.8 French stent if it's a very tight ureter.
Okay. Let us assume that you are not able to pass the ureteric catheter or stent beyond the stone. What is your next step?
So this poses a difficult situation. I will speak to interventional radiology. Sometimes they're able to come to theater and put a nephrostomy. If this is not possible, I'll make arrangements for wake this patient up and arrange for urgent nephrostomy insertion. I would also involve my ITU colleagues as this patient is a septic patient.
Okay. You can bring in ureteroscopy. I know it's not a very safe method and not widely practiced. It all depends upon individual expertise. For example, in the exam, your answer is perfect. But if you wish, if you are confident, you can say that I am a very trained endourology trainee. So I can also bring the ureteroscopy, which can sometimes help me to guide the guide wire correctly on the side of the stone, and if necessary I will use a laser to break the stone into not in the with the view of really doing a laser lithotripsy, clearing the stone, just to clear one edge of the stone to create a passage for the guide wire to get in. And if there is an expertise, this will be much more easier method compared to bringing an IR consultant into theater for nephrostomy placement, because already you took the patient to the theater because the IR support is not available. This is the reason your consenting should be more in the yellow form, generic consent rather than a BOWS specific consent form, so that you can add the need for ureteric catheter placement, the need for ureteroscopy to guide the stent placement. There is a difference between using a ureteroscopy and laser to guide the stent placement and you doing a primary ureteroscopy with laser lithotripsy. There is a lot of difference.
Yeah.
Okay. And I'm very sure 9 out of 10, the examiners will be very happy, because end of the day, patient is in the table, no IR support available. The onus is on you to get the stent appropriately placed. There is no way we can call the patient off and then try something out of the theater. And regarding sending the urine culture, it's better to send the culture from proximal to the stone. So I won't really prepare the urine specimen from the bladder. So you can wait, and once the ureteric catheter is above the stone, that may be more specific to the specific infection rate, and also the bladder catheter, bladder urine will be always diluted with the opposite kidney. Okay, good. Now the stent is appropriately placed. What is your follow-up protocol?
So the follow-up will be to continue with antibiotics to get this patient over the sepsis episode. And when the patient is fully recovered, I will arrange for patient to return for definitive ureteroscopy and laser fragmentation of stone down the line.
Okay. The patient may need to stay in the post-op 1 or 2 days. You may keep a bladder catheter that will help us for urine output monitoring, and also visually it will guide you the clearance of the purulent urine if it's so. And yeah, you can go for elective surgery. Since there is a stent, possibly then elective surgery will be much more easier. Good. Can we go for another scenario?
Yes, please.
Okay. You have a 63-year-old gentleman presented to A&E unwell and a little bit unresponsive. And the A&E team on receiving this patient examination showed ulcerative patch in his right side scrotum extending to the medial side of the right thigh. And because of the appearance, they have directly called you for further assistance. How are you going to proceed?
So I'm concerned that this may be a case of Phonias gangrene. I will go and assess this patient immediately myself, um, and resuscitate this patient in line with ALS protocol. Make sure that airway, breathing, and circulation are fine. I will take specific history for risk factors of Fourniers, including the patient's age, any recent urological instrumentation, any indwelling catheter, any trauma to the genital area, if this patient is diabetic or immunocompromised. I will then examine the patient's genitalia and perineum, looking for features of Fourniers, including skin necrosis or crepitus in this area. And depending on my findings, I will take things further.
Okay. Any other scoring system you can use for these kind of patients?
So if Phonias is confirmed, there is a Phonias gangrene severity index, which can predict mortality in Phonias patients. This scores patients based on physiological and by blood parameters. So it'll be looking at the temperature, heart rate, respiratory rate, as well as blood results like creatinine, potassium, sodium, and bicarb. And and each of these parameters is scored from 0 to 4, depending on how they deviate from normal. And a score of 9 or more is correlates with a higher risk of mortality.
Yeah. So the score is more than 9, the chances of death is almost like 75%,
Yeah,
while the score is less than 9, the chances of survival is around 78%.
yeah.
Good. So, okay, what is your approach? How are you going to treat this patient now it's a Phonias gangrene is established?
So I will bear in mind that this is a urological emergency with high mortality risk. My management approach will be multidisciplinary, involving the ITU team, discussion with microbiology regarding best antibiotic management, and expediting prompt transfer of patient to theater for debridement of Phonias gangrene following initial resuscitation.
Okay.
Um,
What does the resuscitation involves?
so resuscitation involves in IV fluids, IV antibiotics, oxygen, and following the sepsis 6 criteria. It's also important to inform this patient's family early with their consent of what's going on.
Yeah, and you can bring in the ABCD protocol from the American Association for Trauma for Surgeons.
Okay.
And involving the carers is important. If the patient is oriented, you can get the permission from the patient so that you are involving the family or friend, depending upon who is listed as next of kin. And if the
Yep.
patient is not conscious enough to make a decision, obviously you can inform the carer straight away.
Yeah.
And yes, you need to bring the sepsis 6 protocol, even though it's a different second scenario. There is nothing wrong in using it. As long as the sepsis is there, you need to bring the sepsis 6 protocol. Okay, you are taking the patient to the theater. How are you going to proceed, and what steps you need to be aware of?
So in an appropriately consented and anesthetized patient's WHO checklist, I'll place this patient in a lithotomy position. Um, I will insert a urethral catheter to drain the bladder and prep this patient's genitalia and scrotum and abdomen. I will then make an incision over the scrotum or necrotic area and drain any pus, and then debride necrotic tissue up to healthy tissue. And this may be extensive. And so I will continue to debride until I get to healthy tissue and remove all necrotic tissue. I'll then achieve good hemostasis, wash this patient out, and apply a dressing.
Okay. What is
This
the
patient may need a relook in 24 to 48 hours.
yeah? What is the pathology behind the Phonias gangrene?
So Phonias gangrene is a synergistic multibacterial infection involving aerobes and anaerobes, causing tissue necrosis and endothelin occlusion, leading to gangrene of the scrotum and perineal skin.
Okay. What is the importance of the facial demarcation in Phonias gangrene?
So the facial demarcation in Phonias gangrene explains the spread of Phonias, which can actually spread all the way from scrotum to perineum and anterior abdominal wall, even anterior chest wall. Because it spreads along the fascial plane, mainly the collis fascia and the perineum, which continues as the dartus around the scrotum and penis, and carries on as the scarpus fascia of the anterior abdominal wall. So Phonias gangrene can spread along this tissue fascial plane.
Okay. In penis, it's Buck's fascia. Dartus fascia is only in the scrotum. Good. Now you are taking this patient for debridement, and what kind of specimens you will send for?
So I'll send any debrided tissue for microbiology as well as histology. So microbiology for culture and sensitivity, and histology for confirmation of necrosis.
Yeah, so you can send pus and tissue for microbiology. So that will be 2 specimens, and tissue for histology also, just to document the Phonias gangrene. But the histology will be the least important one. Sending pus and tissue for microbiology are the most important one. What is the choice of antibiotic? How are you going to follow up this patient post-op?
So I will discuss with microbiology for guidance on the choice of antibiotics. This will likely be a broad spectrum antibiotics, as well as so broad spectrum like like coamoxiclav, gentamicin for gram-negative cover, and metronidazole for anaerobic cover. However, I will take guidance from microbiology regarding this. The follow-up will involve a second look in theater in 24 hours to perform further debridement if necessary. I would also liaise with my plastic colleagues to attend theater if possible to see this wound, not to necessarily do any reconstruction at this point, but to see the wound, and also medical photography for documentation of the wound as well.
Yeah, when you bring in medical photography, make sure you say that medical photography with appropriate consent.
Yeah.
What is the chances of testes involvement in Phonias gangrene?
So this is highly unlikely because the blood supply of the testis is directly from the testicular artery, which does not get involved in, or is not affected in Phonias gangrene.
Okay, so for example, if this patient has excessive involvement of the scrotal wall, but as you said, the testis alone is spared, how are you going to reconstruct the testis placement?
So I will dress the testis with gelolite dressing, and I could create a pouch around the thigh to keep to secure the testis while healing happens.
Yeah, inner side of the thigh.
Yeah.
You can place right on the right inner side and left on the left inner side of the thigh. And usually the pedicle will be quite nicely preserved, and sometimes that may be the final destination for the testis also. You may not be able to reconstruct the scrotum, but with the help of the plastic surgeons and depending upon the patient's age and expectation, things can be reconstructed. Good. Can you go for a different scenario?
Yes, please.
Okay. You are doing a TURP. It was a TURP for 70 cc prostate, bipolar TURP, went straightforward. Few areas you were quite deep, and there is some evidence of capsular breach, but not bad enough to say as a misguided step. It's more of good in-depth resection of the prostate. Surgery went well, and all chips retrieved, three-way catheter, 24 French placed, and patient is comfortable. This surgery was completed around 11 o'clock in the morning. You are doing the evening ward rounds, and except this patient is having high swinging temperature, and post-op ward is a bit concerned. What is happening?
So high temperature post TURP. I'm concerned that this patient has become septic post-operatively, and so I will resuscitate this patient in line with the ALS protocol, and also instigate the sepsis 6. I will look at this patient's preoperative urine cultures to see if there was any previous positive cultures. I'll double check antibiotics administration intraoperatively to see if this was the right antibiotics. And following sepsis 6, I will start this patient on broad spectrum antibiotics after sending urine cultures and blood cultures and seeing
Okay.
how they respond.
Okay. What may be the reason for the high swinging temperature?
Um, Post-operative urosepsis could be a reason. It could
Okay.
also be a chest infection post-operatively. However, this is probably too soon to happen. But the most likely thing would be untreated urinary tract infection before TURP, which is then caused urosepsis in this patient.
Yeah. The other things which you need to include in your answer is I will review the antibiotics given before the surgery and make sure that it is, even though sometimes we discuss the antibiotic, we need to make sure that the patient's drug chart has a documented antibiotic given time and the dose. And the other thing is about the local examination, whether the catheter is draining well, whether the irrigation is going in freely, and there is no evidence of any bladder distension in the per abdomen examination, color of the urine. So you can bring your discussions
Okay.
into the
Yeah.
local examination also. How will you take it forward? The catheter is draining well, irrigation is doing fine, patient is comfortable. What is your change of protocol from now?
So I'll look at the previous urine cultures and give broad spectrum antibiotics as well as gentamicin to cover for urinary tract or urosepsis. I would have sent off urine sample before starting antibiotics, as well as taking blood cultures. And sepsis 6.
Yeah, that's important. Okay, this patient is getting gradually improved with the change of antibiotics. So one thing you need to bring in is there is a definite need for change of antibiotics. If you have given only the gentamicin, sometimes it may be only like 160 milligram, because some trust give 160 milligram as a protocol. You need to change the gentamicin to therapeutic 5 milligram per kg. And also you can add broad spectrum antibiotics, any other things based upon the antibiotic guidance from the microbiology. You may have to think whether the patient has to go for a general ward or he needs any intermediate observatory ward or something like that. You
Okay.
can complete the answer by saying that I will call the on-call team, both
Okay.
the registrar and the consultant, so that I mean, the thing is, the idea is this is what actually you do. But in the
Absolutely. Yeah.
exam, yeah, in the exam, our mind is so tuned to say only the urological aspects. The easiest thing is to think as if what you will actually do. So that will give the examiner a confidence that, okay, this guy has come across the situation and he is ticking all the boxes.
Yeah.
So communicating with the on-call team, and you can even go to the level of saying like, if time permits, I will give a ring around 9 o'clock in the night before I go to sleep, to make sure that the patient is doing fine. Nothing wrong in
Okay.
it. And
Yeah.
once you blossom as a good consultant, these are all the things automatically become your character. And why can't we exhibit it? There is no shame in exhibiting the good characters.
Yeah.
And you can complete the answer by saying next day, depending whatever my timetable, I will try to visit the patient to reassure him, or at least I will coordinate with the team which is doing the morning ward rounds. So that becomes more complete.
Yeah.
Okay, good. We'll go for another scenario.
Okay.
8-year-old boy was brought by his stepdad into the A&E. He was complaining of pain and discomfort in the left testicle for the past 2 hours. How are you going to evaluate the child?
So I'm concerned that this patient with a 2-hour history of left testicular pain has testicular torsion. So I'll go to A&E and see this patient immediately. Take a history, examine the patient. In my history, I'll establish the duration, if this is sudden or gradual onset pain, and the severity of the pain. I'll ask if this has happened before to see if this is an intermittent torsion. I will examine the patient with the patient's consent and a chaperone. I'll look for any signs of redness and swelling. I'll check for chromosteric reflex. I'll examine the normal side first for consistency and any tenderness. Then I'll examine the left side for any tenderness, swelling, hydriding testicle. However, with this 2-hour history of acute testicular pain, the only way to confirm or rule out a torsion is by taking the patient to theater for emergency scrotal exploration.
Okay. How will you get the consent for the procedure?
So in an 8-year-old boy, I will have a discussion with the patient and the parents, discuss the risk benefits of scrotal exploration, and the alternative, which isn't really much in this case. The procedure itself involves an incision to deliver the testicle and inspect it directly and see if it's torted. If it's torted, then I will untwist it. I would also explain the risk of the testicle being dead, in which case he will require an orchidectomy on that side and an orchidopexy on the contralateral side. If the testicle is, however, twisted and viable, I will untwist, fix that side, and also fix the contralateral side. And I will also briefly mention the differential diagnosis of a torted hydatid cyst, in which case I will excise the cyst and not do a fixation.
What is the role for antibiotics in this procedure?
So I don't routinely give antibiotics in my practice for acute scrotal exploration in a kid.
Good. But having said that, if there are any signs of inflammation intraoperatively, you can give antibiotics intraoperatively. Keep that
Yes.
option open.
Yes.
It is a clean surgery. You can bring terminologies like this is a clean surgery, so there is no need for antibiotics. But
Yeah.
depending upon the intraoperative appearance, I may have to top the patient with an antibiotic if there is some signs of, say, mild necrosis. But having said that, the testis is still viable, etc.
Yep.
And yeah, what is the role for testicular prosthesis in these type of patients?
So in an 8-year-old boy who is still growing, I would not offer a testicular prosthesis at this point. And also, it's not really recommended to put a prosthesis through the scrotal incision because of risk of extrusion. However, prosthesis can be offered on a later date at an elective period. So this will be my approach.
Okay. This patient presented within 2 hours. There is a true testicular torsion, and you are able to untwist it, and there is a good blood flow, and you are able to preserve the testes. As you said, you have also done orchidopexy for the opposite testes. What kind of suture material you use for orchidopexy?
So I'll use a non-absorbable suture. So I'll use a 4-row and perform a 3-point fixation.
Okay, why 3-point fixation?
To prevent a rotation in any axis.
Yeah, how you can explain is a 2-point fixation will eliminate the twisting in only 2 directions, while the rotation can happen with the 2 points as a fulcrum. So a 3-point fixation will eliminate the rotation happening in all the 3 coordinates. Okay. X, Y, and Z.
Yeah.
Okay, good. So this patient recovers well, and I just want to add one in the consent. This patient is obviously in a pediatric age, needs consenting from next of kin. I purposefully said the patient was brought by the stepdad. So you can bring in that I will check the next of kin, and if the next of kin is mom, I will involve mom for consenting, because there is a good possibility mom will be the next of kin and stepdad has no rights to decide anything. So yeah, that's why I brought that in initially. Okay,
yeah.
We'll go with one more last scenario. Is it okay with you?
Yeah, that's fine. Yeah.
Okay, good. You are on call, and you have finished your normal urology routine, and there is not much pod list for urology. You're doing your admin work, and you got a call from the gynecology team that they are doing excenteration for the previous cervical cancer post-radiotherapy patient because of the lymph node involvement and further worsening of the condition. In that process, the bilateral salpingohysterectomy went well. There is no concerns with that. But in the urine was quite rosy red intraoperatively. So the surgeon managed to do a cystoscope, and she found a kind of a suspicious red patch in the floor of the bladder. And peritoneal examination is fine. They have even closed the vault. So they have asked you for an opinion. What will you do?
So is this patient still in theater?
Yes, still in theater.
Okay. So I am concerned that there may be a bladder injury here. And so I will speak to the surgeon directly to find out what the details about the operation and if there was any suspected attachments to the bladder or dissection around the bladder which could cause bladder injury. I will request. I'll speak to the theater matron or sister to keep available a cystoscope, ureteric catheter, contrast, and I'll also request for X-ray to be to fluoroscopy to come to theater. I will then go to theater and assess this patient, perform a cystoscopy, myself, and bilateral retrograde studies to make sure that the bladder is intact and that there isn't any ureteric injury.
Okay, so the ureter seems to be separate, and the patch in the floor is quite suspicious, but not like an overt injury. And you're not able to demonstrate anything in the perivaginum also. The rest of the bladder wall being quite normal. How will you do a cystogram if needed?
So I'll do an on-table cystogram by instilling 300 mils of contrast, 50-50 dilution, on table, and taking X-rays in the AP and lateral directions to look for any extravasation of contrast around the bladder.
Okay, just two things to add. The 50-50 is the correct proportion to start, but you can add that based upon the extent of the opacity I'm getting in the IA, I may have to have a neat contrast if needed to top up, or sometimes even 50-50 will be too high, and maybe in the next syringe you may have to dilute it to say even 30-70 or even much more dilution. So don't get fixed up with 50-50. And the next thing is the contrast filling should happen by gravity. So you can use a catheter and have a bladder syringe, and you can pour the contrast into the bladder syringe, and it should get into the bladder under gravity. And yeah, injecting, even though you can do it quite gently, it can cause extravasation. It can cause injury, or a small subclinical injury may become an overt injury just because of our iatrogenic acts. There is evidence of leak of the contrast posteriorly from the bladder wall, and you're able to demonstrate it in the lateral C-arm view. So how are you going to proceed?
Okay, so with a little leak, which is not massive, as described, and it's posterior, which would be extraperitoneal, I will manage this conservatively with leaving an indwelling catheter for 2 weeks and repeating a cystogram 2 weeks later.
Okay, in this aspect, you need to add few things. Number one, you need to make sure that there is no obvious communication of the leak to the vagina. Then in the case like vesicovaginal fistula will develop and progress further. You also need to ask the examiner or bring the scenario that I will be guided by the stage of the laparotomy, what they have done. For example, if the laparotomy is already closed and skin, everything is sutured, I will try to see if the patient will be suitable for a conservative management, if it is a retroperitoneal leak, and also if it is a minimal leak. But if the patient abdominal wall is not yet closed in layers, then I will try to inspect and try to do the primary repair also. Because the only concern is the patient had bilateral salpingo-oophorectomy and hysterectomy, and there is, even though it's retroperitoneal, there is a suture line in the vaginal vault.
Fistula,
and so the chances of vaginal vesicovaginal fistula is so high, even though it's retroperitoneum, because of the suture line. Okay, good. I'm quite happy with the scenarios, and we have tried to stick on to the evidence and also to bring in some clinical expertise in that. You have any questions on any of the scenarios we discussed today?
No, I think we've covered quite a lot of emergencies this morning. So no, that's very helpful actually. Broad ranges of emergencies. So thanks for that.
Good. There are a few other emergencies, like for example, ureteric injury, urethral injury, and few other things. There is always some scenarios which we can cover in the 10-minute sessions, which will be starting within a week or two. Okay.
Okay. Yeah.
Good. Thank you for everyone joining in this session, and we will continue this session till the exams. And we are guided by the trainees, what table they want. Say, for example, you opted to do BPE for Monday, we will try to tailor the questions. We are keeping the scenarios and questions ourselves so that it will be a natural exam scenario. Okay.
Yeah.
And so you can select the table, but we will select the scenarios closer to the exam. We will also do the last 1 week or 10 days, any table, any scenario sessions. So that will really put you into deep waters and real exam day.
Yeah. Thank you.
Okay. Good. Have a nice rest of the day. Bye
You
for
too.
now.
Bye-bye. Bye.
Bye.